We have two speakers today, one from London and one from Tokyo, and I'll just briefly introduce them. So Dr. Maki Sugimoto, joining us from Tokyo, is a surgeon with over 30 years of clinical experience. He's a professor at Teikyo University, and he is the founder and CEO of Hollow Eyes Inc., which is a medical technology company specializing in precisely the area that we're talking about today. And then our second speaker, Dr. Martina Giannaru, is a reader in surgical cancer technology at Imperial College London. She has a PhD in object recognition from the Department of Electrical and Electronic Engineering at Imperial. And she is currently a Royal Society Research Fellow at the Hamlin Center for Robotic Surgery at Imperial. So this is the timeline. That was my introduction. And we're going to have roughly 25 minutes presentation by each speaker before we go over to Q&A with all of you listening. So please, over to you, Dr. Sugimoto.
Thank you for introducing me. This is a very great honor to have invited me as a lecturer. So today I would like to show my previous R&D and research work for image-guided surgery using the VR and AI and robotics and metaverse. This is COI. In pre-operative conference like that, spatial understanding in surgical planning is crucial. Then how many hours do you actually spend on this? Do you consider? Do you have you imagined? And more than 3 or 4 hours before surgery for person. So surgical techniques remains unsystematized, relying on patient knowledge, which makes their transmission and standardization challenging. So surgeons rely on 2D images and subjective expertise, leading to inexperience and skills. So this is so-called tacit knowledge in the surgical technique. There is not systematized. And just as a car navigation like you use, surgical navigation helps surgeons navigate intricate anatomy and reducing risks for enhancing accuracy. So you cannot use an old map to explore a new world, okay? So we developed the surgical navigation system for individual patient like a car GPS. However, the conventional 2D displays cannot fully convey the 3D spatial positioning of organs, lesions, and the instruments reconstructed from CT, CAT scan, and MRI scans. So, current single modality imaging for preoperative surgical planning and intraoperative surgical guidance using CT and MRI has certain limitations in clearly identifying the actual anatomy, which is crucial for surgeons to make correct intraoperative procedure. So we usually use the paper printed out from a patient CAT scan like that. It's no work. Even through we have 3D data from CT scans, why do we only view it on 2D paper or 2D display? The problem is the display, okay? So that's why the surgical technique is not systematized, and that is so-called tacit knowledge, okay? So we developed like the technology like that to improve the gap between surgeon skills level and the spatial awareness. We developed a surgical guidance system using extended reality. Extended reality means virtual reality, augmented reality, and mixed reality with the metaverse. So we developed a web-based XR application named Hollow Eyes, and I'm a founder of this company. From CT or MRI images, organs and lesions are extracted into colored 3D polygons. So we represented it into spatial and real space using our original web-based XR application. We have integrated a commercially available cloud service that accomplished XR in only 5 minutes. And we already got the class 2 medical device certification in Japan. This is the medical device. So all the surgeon have to do is that only upload the polygon, and after 5 minutes, you can download the VR application to your head mount display. So this is a cloud service that automatically convert medical images captured by CT and MRI into VR, especially reconstructing the anatomical structures. So like a car GPS. So we are using this kind of technology, XR, extended reality. So XR means the umbrella term that converts immersive technology like VR, AR, MR. The VR, virtual reality, means immersive yourself in the completely artificial world, in the digital world, okay? So augmented reality means overlaying digital layers of contextual information into the built environment. And mixed reality is an interactive mix of VR and MR. So the difference is it's very simple. The background is digital or actual environment. The older people sit down and ask, what is it? But the boy asked, what can I do with this? So the point is the virtual reality technology is the stereoscopic view. So we leverage side-by-side display technology on VR headset and smartphones to enable stereoscopic vision of medical imaging for right eye and left eye. So this is so-called 2D vision. But using the two different display, we can offer the 3D vision using the parallax technology. So this approach ensure a highly immersive 3D experience by delivering distinct visual inputs to each eye. So we made this kind of technology so we can upload the CT data of the patient, and after 10 or 15 minutes, you can upload the polygons of each organ, like cancerous cell and organs and then blood vessels. So nowadays we can use the AI automatically segmented each organs. So using the AI technology, you can select each organ from the patient data to reveal the 3D polygons of each organs or cancerous lesions or tumors like that. Then you can export each files for a virtual reality. So after selecting each organ's area of the interest, you can reveal the 3D in the air. So nowadays we are using the video pass-through head-mount display because the several cameras were located in the surface of the virtual reality goggles, and this camera can show the actual image into a virtual reality monitor for each eye and for each eyes, right and left. So using the video pass-through, you can see the actual environment through the virtual monitor like that. This is the video pass-through function. So now you can see the patient CT data moving in front of you, and we can overlay it into our actual 3D printed organs for training purposes. So video pass-through function on the head-mount display refers to the headset ability to show you a live view of your real-world surroundings through its cameras, allowing for mixed reality experiences where virtual elements are overlaid on your actual environment. So augmented reality technology are usually used with the smartphone or tablet. But using the head-mount display, you can see the actual environment during the actual surgery, where even wearing the sterilized glove. This is the mixed reality. The mixed reality is the merging and the real and merging of real and the virtual world to produce new environments and visualizations where physical and digital objects coexist and interact in real time. So we apply the holography like 3D guide to organs, lesions, and procedures based on CT MRI images of the individual patient to create stereoscopic view in the real space above the surgical field to allow viewing in all directions. So this is the beneficial application of the MR devices. Holographs are given presence in the world, in our world, by remaining in place as we move around about in space. When we share these coordinate systems between devices, we can create a shared experience that allows us to take part in a shared holographic world. So we already published the English paper in Annals of Surgery. The impact factor is more than 9. So furthermore, allowing users to move around and share the modules enhance surgical planning by optimizing resection area selection and preventing anatomical misidentification and minimize both unnecessary bleeding and miscommunication. So using the intraoperative fluoroscopy, we can rebuild the actual status of the patient during the surgery. That we can merge the knowledge between the young doctors and the elderly doctors. This is the laparoscopic pancreatic surgery. And this is a robotic surgery for pancreatic cancer. So we can use the patient data in front of the patient using the sterilized glove to manipulate the visual direction as you want. And nowadays we are using the Apple Vision Pro to show the patient data in the area. So the Apple Vision Pro have the high resolution display, 4K and 4K. So the visual data is very rich context to navigate our procedure. So in our surgeries, we could accurately reproduce the organs, arteries, veins, peripheral tissues, and tumors from the CT as holography, and display the dissection line to guide surgical procedures in a sterilized space above the patient abdomen during the actual surgeries. So this is a renal cancer dissection to reduce to prevent the renal function after surgery. And this is the prosthetic cancer surgery for using the Da Vinci robotic surgery. And this is the uterus dissection for uterus cancer using the laparoscope. And this is the breast cancer surgery to detect the lymph node metastasis in the actual area. So we can also merge this data to actual patient location on the breast. So now you can see the location of each metastatic lymph node in green. So this is also available for implant for orthopedic surgery. So replacement of artificial joint for a hip joint, and we can select the correct direction to put the needle into a patient. And this is a spine surgery. We need to put the several screws on the back, on the spine. So it is very hard to detect and then select the location and the position and the angle to the patient for a line of the insertion. However, the holographic CAD can navigate you to the line in front of the patient in the green holographic bar. So surgeon, all the surgeon have to do is only put the needle into along the green holographic line. It's very easy. So this is available and useful for educational purposes for young doctors. For not only for a surgeon, but also the internal medicine doctor, physicians, they are using the ultrasound to put the needle into a liver cancer to hit the cancerous cell using the ultrasound. So we can show the correct portion of the line, insertion line, using the holographic guide to show the therapeutic procedure. So this is also available for endoscopic procedure guidance. And using the fluoroscopic data of a biliary tree, we can show the very strict and complex biliary tree reconstruction in the air during endoscopic surgery. So now you can see the endoscopic procedure for a biliary cancer patient to put a stent into an obstructed biliary tree. So the endoscopist can select the correct line and the direction and the route to put the needle into a biliary tree. And we already published several articles. And for the interventions for a brain aneurysm, it's very easy to shape the catheter for individual patient shape. So using the holographic patient data, we can make the shape of the catheter for each patient, like a customized device, and to put the needle into a patient aneurysm of a brain. This is a TAVI, transcatheteral the valve, heart valve replacement, aortic valve replacement using catheter. And we can have a simulation before the surgery. And even during this operative procedure, we can merge the correct location and the position and the size of a stent for each patient. So learning is the experience. Everything else is just information, okay? So we want us to share this the experience itself between the distant part. So using this spatial immersive telesurgery training system with robotic 3D endoscopy, we can share the movement itself and the voice itself between the metaverse environment for several doctors. So using a spatial immersive telesurgery training relives skills techniques using metaverse and XR between several doctors. And we can merge the endoscopic 3D data and 3D reconstructed CT data emerging in a metaverse environment. And then now the young surgeon can learn how to move their arms along the robotic arm movement. So we can share it even on a smartphone, iPhone, and the cardboard VR goggle, only $1, $1. And then you can put this data to your own smartphones, and we can share it for educational purposes. Even the student are more than 100 people, and it's very low cost, only $100 for the virtual reality class educations, because they are using their own smartphone, bring your own device, BYOD. So we already applied on more than 70 medical institutions in Japan for all kinds of procedure using the surgical devices or robotic surgery. And not only the surgeon, but also the physicians using our system in Japan. And not only the surgical procedure, but the examination purposes or IVR, interventional therapy. We already published the more than 200 medical thesis papers, and we already got more than 30 hours from internal or international or national medical hours. We already have many grants. Okay, in summary, this is, I think, the imaging and the display future. So in the past, we are using the 2D imaging on the X-ray. And now we are using the 3D reconstructive data in the 2D display. But in the near future, 3D hologram in the 3D space is common, I think. This is so-called extended reality or metaverse. I think this is not the nice to have already. It is must have, like a painkiller for patient treatment. Okay, thank you for attention.
Great. Thank you very much, Sugimoto Sensei. Okay, let's go straight on with Dr. Janaru.
Hello, I am Martina. The use of AI in medical practice has evolved significantly during the last decade. Artificial intelligence has moved beyond experimental pilots, and it is now embedded in several areas of routine medical practice, especially in areas where pattern recognition, prediction, and automation add a clear value. One of the most mature areas is medical imaging. We have many AI models which are used extensively right now in radiology and pathology in order to detect abnormalities, grade tumor, and quantify biomarkers. And the advantage of using AI in these areas is that we can reduce inter-observer variability and workload pressure. Another major area is the clinical decision support, where we have now AI models that can predict and estimate risks for conditions such as sepsis and clinical deterioration of the patient, therefore enabling earlier intervention and proactive care. The aim of using the AI in this case is more to augment rather than to replace the judgment of the clinical teams. AI is also increasingly used to streamline administrative and operational workflows. We have AI models which can generate automatically clinical documents or summarize clinical notes, reducing the workload and the burden of the clinical teams. Recently, we have also seen virtual assistants and chatbots which can support the patient communication by answering common questions, providing medication reminders, and guiding patients through pre or post-procedure instructions. AI has also reshaped surgery by shifting it from a discipline dominated mainly by manual skill and experience to an area which is augmented by data, analytics, and real-time decision support. Right now, we have image-guided and robotic systems which have already improved the precision of minimally invasive surgery. However, AI adds a new layer of contextual intelligence. For example, we have AI models which can analyze intraoperative imaging and video data to assist the surgeon in identifying anatomical landmarks, delineating critical areas, and therefore reducing intraoperative surgical errors. Also, AI has enabled the objective assessment of surgical skills, improving training and the quality of treatment. And recently, we have seen an increasing interest in developing AI models that can predict surgical complications and surgical errors, allowing therefore timely intervention and improving the patient outcomes. Focusing even further, AI has been used extensively in surgical oncology, and the aim here is to analyze information from multiple sources in order to enable the surgeon to make informed decisions and provide patient-specific treatment. We know that the aim of surgical oncology is to resect the entire cancerous area without affecting healthy tissue. However, in practice, this can be particularly challenging, and especially in neurosurgery, it may be very difficult to tell where the healthy tissue stops and where the tumor starts. Methods which are used right now in the operating theater during surgical oncology may have significant limitations intraoperatively or cannot provide complete detection of tumor margins. For example, intraoperative MRI disrupts the surgical workflow, while fluorescent imaging cannot always highlight the entire cancerous area. Recently, we have advances in biophotonics techniques, such as the probe-based confocal laser endomicroscopy, which allow the visualization of the tissue at microscopic scale during surgery. For example, the PCLE can apply these small flexible probes that you can see at the top right part of your screen on the tissue surface, and it can reveal cellular morphology. And this can help the surgeon make decisions during the operation. At a different scale now, macroscopically, we can reveal tissue characteristics by using hyperspectral imaging. And hyperspectral imaging is a rich imaging modality which can capture information both in the spatial and in the spectral domain. And so far, preliminary methods have shown that it can play a significant role in detecting the boundaries of tumors in surgery, in oncological surgery. So by combining multiple imaging and sensing techniques, we can therefore enable the surgeon to make informed decisions and guide the surgery in order to resect the entire cancerous area without causing any iatrogenic injury. And this is the part where my work focuses as well. So I am aiming to develop a robotic platform which combines multiple imaging techniques to assist surgical navigation and enable intraoperative tissue characterization in order to improve the efficacy and safety of oncological surgery. I carry out this work at the Hamlin Center for Robotic Surgery. The Hamlin Center has been established for developing safe, effective, and accessible technologies in three main areas: imaging, sensing, and robotics. Our work focuses on technological innovation, but we have a strong emphasis on clinical translation and direct patient benefit with a global impact. At the Hamlin Center, I lead the Cognitive Vision in Robotic Surgery group, where we are developing computer vision and AI methods to assist surgical navigation, enable autonomous execution of surgical tasks using robotic platforms, assist online diagnosis support, enhance the intraoperative visualization for the surgeon, and finally provide objective methods for surgical skill assessment. So what we are doing in our work as part of developing what we call the neuro platform is that we are trying to use the cameras which are already available in the operating theater to get a 3D structure of the surgical scene. And we are using these anatomical structures to guide the scanning of the tissue with robotic tools which are holding our imaging probes. And by scanning the tissue, we can capture tissue characteristics which are analyzed using AI methods in order to characterize the tissue and make decisions about tumor resection. Regarding the intraoperative surgical navigation, we have developed a plethora of techniques to recover the depth of surgical scenes and also the 3D structure of the surgical scenes. We have used traditional computer vision methods, and more recently we have developed more modern techniques based on deep learning. We have combined the 3D reconstruction with tracking of the tissue along time to estimate the deformation of the tissue and the dynamics in a surgical scene. And in our work, this has been combined with a biomechanical model in order to estimate applied forces on the tissue surface without using any external force sensors. And this is very important, especially in microsurgery and neurosurgery, where the threshold for the applied forces can be as low as 0.3 newtons. And even for an experienced surgeon, going beyond this threshold can be very, very easy. So by providing this alert with our system, we can prevent iatrogenic injury, as you can see on the video here, where the aneurysm bursted because the surgeon pressed with higher force than what it should be. Also, in our work, we have proposed what we call see-through vision. So the idea here is that during surgery in constrained environments, the surgical tools may occlude a significant part of the surgical scene. So what we are doing is that we can detect the occlusion, which in our case is a surgical tool. And then we have developed an AI model which can learn the content of the scene underneath the occlusion and present this to the surgeon intraoperatively. So again, the aim here is to prevent iatrogenic injury by allowing the surgeon to see what's underneath the surgical tools which are interacting with the tissue. In the middle, you can see a video from a surgery with the Da Vinci. On the far left, we are segmenting the shaft of the tools, and on the far right, we can see the view with the tools completely removed. So once we have this 3D structure of the surgical environment, the next step is to apply our robotic tools to help with the scanning of the tissue. The probes which are used in probe-based confocal laser endomicroscopy, PCLE, are very small and very flexible. And in discussions that I had with clinical collaborators, Professor Haralambaki, who has used this in the operating theater, if we try to do this scanning of the tissue with these probes manually, it can be impossible to capture good quality endomicroscopic information and allow diagnosis. So in our work, we are giving these probes to a robot, and we can achieve much more repeatable and systematic tissue scanning. To achieve this, we have developed AI models which can actually regress the distance between the probe and the tissue, and also the orientation between the probe and the tissue. So the aim here is to keep the probe within a working distance from the tissue surface and perpendicular to it in order to be able to capture good quality endomicroscopic information. On the video on the left, you can see that when the probe starts at the beginning, we have no endomicroscopic information, everything is black. The image becomes blurry and we start with a blurry image, which becomes clearer and clearer as the probe is brought from our model with a robotic system to the optimal position. And the same with the video on the right, where you can see the optimization of the orientation of the probe. And the best quality information is when the probe is perpendicular to the tissue surface. So in our work, we have integrated these AI systems with a robotic platform. In our case, we use the SmartPod robot. And as you will see, during scanning, our model can tell whether the probe is within the working distance from the tissue surface or not. And then when the probe it is not, then the robotic system will rectify this position in order to bring it to the optimal position with respect to the distance and with respect to the orientation as well. And once we have captured all these tissue characteristics from the tissue surface, the next step is to analyze them and assist the surgeon into making decisions. Probe-based confocal laser endomicroscopy is a relatively new technique, and it may, although we may provide very nice videos to the surgeons intraoperatively, they may not be able to understand what the videos show, as they are not histopathologists who review histopathological information routinely. So the aim of our work is to develop AI techniques which can automatically analyze the content of this data and help the surgeon to make decisions. We have developed models which can classify between two different tumor classes, brain tumor classes, namely meningioma and glioblastoma, which are the most common benign and malignant brain tumors. We have achieved very high classification accuracy, about 95%, when we are analyzing single frames, and about 98% when we're analyzing small parts of the captured video. Here, I would like to show how challenging this classification can be. On the first row, you can see samples from meningioma data, and on the third row, you can see samples from glioblastoma data. The second and the fourth row show the false classifications, and actually the second row can shows samples of data which are actually glioblastoma, but they have been detected as meningioma. And you can see the similarity between these samples to the actual meningioma samples. And the same holds for the glioblastoma case. But the surgeons do not want to use AI as black boxes, and they will never trust these black boxes. So what we need to do here is that we need to help the model explain the predictions that have been made. And in our work, we believe that if the model actually pays attention to areas which are clinically meaningful, then it will make informed decisions, and the surgeon can gain more trust to these predictions. So, for example, we know that the meningioma is characterized by these black blobs, which are called psammoma bodies. And also glioblastoma is characterized by hypercellularity. So if the model can pay attention to these areas, then the surgeon will gain trust and will accept the predictions. Recently, we developed a method which can actually, at the same time, classify meningioma and glioblastoma, ex vivo and in vivo data, and also it can present to the surgeon areas where the model has paid more attention in order to make these decisions. And as you can see, these areas coincide with psammoma bodies on the meningioma case and with areas of hypercellularity in the glioblastoma case. Now, regarding tissue characterization at the different scale, at microscopic scale now, we need to segment the hyperspectral volumetric data. And as part of our work, we have developed a method which actually combines classical classification methods which work only on the spectral information with modern interactive segmentation methods. And the advantage of using interactive segmentation in this case is that we can leverage the expertise of the surgeons and improve the performance of fully automated methods. And at the same time, it can enable the classification of tissue classes which have not seen before. And this is very important when we're talking about tissue characterization during surgery. Here I show an example of the result of our model. At the top left, you can see the data that we capture from the operating room. Inside the bottom ring, the black ring, we have the tumorous area. And as you can see on the top right image, the classification provided if we use only spectral information includes the tumorous area, but also it includes many areas which have nothing to do with the tumorous part. At the bottom, on the first and the second image, you can see the classification if we use only spatial information. And we see that actually these models respond to the areas inside the ring, and they act more like an edge detection. But the result of our method, the third image at the bottom, outperforms both of the other methods. And this is because our method actually can detect the entire part inside the black ring, but also we believe that the area which is highlighted around the ring corresponds to infiltration of the tissue, of the tumor around the tumorous area. And in our work, we have combined these two modalities, the PCLE and the multispectral information, into a multimodal imaging platform. We have attached the multispectral camera on the surgical microscope, and we are able this way to see the surgical scene and also detect and track the PCLE probe and map information from both imaging modalities on the same coordinate frame. We have used our method to analyze hyperspectral data in order to detect the tumorous area and the healthy area, which is at the top right, on the top right image. As you can see the prediction, the green is the healthy part and the red is the tumorous part. And also we have used the PCLE information to locally scan the tumorous area and identify the boundaries of the PCLE. And then in the middle on the right part, you can see the overlay of the information provided from these two modalities, which can highlight intraoperatively the tumorous part which needs to be resected. So overall, this is the vision that we have in my group. We would like to combine multiple imaging techniques and sensing techniques that can be used intraoperatively to enable the surgeon to see a visualization like this, where they will be able to see exactly the boundaries of the tumors and resect the tumorous area effectively and safely for the patient with reduced workload for the surgeon. Still, we have a long way to go regarding the wider adoption of AI in surgery. We need to make sure that we have data which satisfy our requirements in terms of size and quality, data sets which include data of underrepresented classes in order to achieve generalizability across institutions, geographies, and patient groups. Also, we need to make sure that the AI methods satisfy explainability and trust requirements from the surgeons. We also need to overcome regulatory and validation issues. And we need to make sure that we respect the ethical considerations in terms of data privacy, consent and transparency. And also we develop AI models which can easily be integrated into the workflow of the surgery. So far, most of the developed systems are now task-specific tools which operate under the human supervision. And the aim of this implementation is not to diminish the role of the surgeon, but more to reframe it. The surgeons are acting more as supervisors of intelligent systems. They're making high-level judgments while delegating certain tasks or monitoring functions to the technology. So over time, I believe that the AI will support more consistent outcomes. It will reduce unwanted variation, and it will enable complex procedures to be performed more accurately, safely, and reproducibly. And this will be done by making the partnership between the surgeon and the AI and robotic systems closer, by changing the training of the surgeons to emphasize understanding of AI outcomes, and also by making the collaboration between surgeons with engineers and data scientists closer. So a big thank you to my technical and clinical collaborators and my entire team, and also to my funders. Thank you very much.
Well, I certainly learned an enormous amount from both of you about where things are going in this area. No doubt it'll change very rapidly, so we'll need to do another of these webinars in a year or so, probably in a few months or so. But thank you both very much for sharing your expertise with us. And thank you to the audience for joining us today.